Good morning, everyone. Today, the May 20th at 8:05 Eastern Standard Time, we present to you the live peripheral intervention case from Mount Sinai Medical Center in New York City. I'm Vishal Kapoor, one of the moderators, and this is Dr. Jose Wiley here. We'd like to go ahead and present a complex and an interesting case this morning. Of course, we'd love to hear questions from you, so during the case or after the case, if you have any questions, please email us at info@peripheраlinterventions.org. And just as a reminder, for our annual symposium, the Complex Coronary and Cardiovascular and Valvular Symposium, the dates are June 17th through 19th. Please don't forget to register. You can go online at cccsymposium.org. And this year we'll have an exclusive session for the endovascular and the endovascular fellow symposium. So I'll let Dr. Christian and Dr. Guja take it from here and introduce the case.
Good morning, Jose and Vishal. I'm glad Vishal gave the interlude into the symposium. I'd like to welcome all of you to our cath lab for our May 2015 case presentation. So in the cath lab, we have Dr. Karthik Guja, Ray Lascano, we have Krishna, our fellow, and then we have Ricky, our tech, and Elizabeth, our nurse for this particular case. So I want to welcome all of you. We've got an interesting case. It's not particularly complex in the sense of the difficulties. However, I think it presents a lot of management options that we need to speak about as we go forward. So without further ado, I'd like to ask Dr. Guja to go ahead and talk about this particular case, present the history, and then I'll go over the angiogram.
Hi, good morning, everyone. We have a 61-year-old male patient with resting left lower extremity pain. Makes it a Rutherford class 2 category 4 and Fontaine class 2B, or you can say actually going to 3. But despite analgesics or for about more than 3 weeks, he has a history of, prior PTA of the right SFA, coronary artery disease, PCI of RCA about 6 months ago for an inferior MI. He has cardiomyopathy, most likely ischemic cardiomyopathy, EF of 30%, hypertension, dyslipidemia, reflux disease, and prostate hypertrophy. He is on aspirin, Plavix, Coreg, Crestor, Lisinopril, hydrochlorothiazide, hydrolazine, Proardonyx, and Flomax. Can you go to the next? So on presentation, his vitals are 140/70. It's pretty stable vital signs. Left AT is Dopplerable. PT with faint Dopplers, definitely not palpable pulses. ABIs on the left are 0.5 at presentation, and the duplex shows that in the mid to distal left SFA, the velocities have tripled to 275 from 84, and there's a diffuse long lesion, and on the Doppler we can clearly see that it's calcified, and patient has significant moderate to severe infrapopliteal disease with monophasic waveforms. And I would defer to Dr. Krishnan for the angiogram.
So I want to show you what we found. So it's very interesting. So we know this gentleman. We'd fixed his right side in the past, and we had taken pictures of his left SFA. And at that time, he was not claudicating. He was claudicating, but we had him on medical therapy, and we're planning on fixing his SFA. Over the last 3 weeks, he's developed more rest pain. Excuse me, and he's actually had tissue breakdown now starting 2 days ago in his right anterior tibial artery dorsalis pedis distribution in the great toe. So when we did the angiogram, I want to show you the angiogram so you can see what it was. So he's got this focal SFA, as you can see in the mid SFA, just above the adductor canal, and a diffuse segment of calcification al flora to see you with lumpy, bumpy stuff at that stage. Thank you, Liz. And then when you go to the next frame, you'll see that the popliteal artery in general is okay, which I'll show you in a second. But then you'll see below the knee, he has a robust posterior tibial artery coming down along with the perineal, which has some disease, and the anterior tibial artery occludes in the middle. And then when you see in the foot, actually, I was surprised to see how low the ABIs were, because when you see the perineal artery actually leads before the posterior tibial artery. Posterior tibial artery is diffusely diseased in the foot, and the anterior tibial artery actually reconstitutes via the perineal artery. So if you go back and you look carefully at this angiogram, you can clearly see that I think the combination of the anterior tibial artery, which is stenosed and occluded, and the peroneal artery, which has proximal severe stenosis, is probably the likely reason why this guy has such low ABIs along with his SFA, and now has tissue loss with the occluded anterior tibial dorsalis pedis, as well as the peroneal artery. So it's interesting. It's important when you look at this angiogram to look at why this is important in causing the tissue loss. Even though he has a posterior tibial artery, he's a diabetic, and obviously he's got multi-level disease. He's got a tight SFA and a tight anterior tibial. And the reason I'm presenting this case is to talk to everyone about multi-level intervention. So in this particular case, we need to take care of both the SFA first. We need to do that safely. And then we need to go after the anterior tibial artery, see how the flow is into the foot, and if necessary, go ahead and we'll discuss whether we should intervene on the peroneal artery as well. So we've got a lot to do today. So I'm just going to go over ask Dr. Guja to go over what we plan to do on this particular case with the SFA, and then once we do the SFA, we'll go ahead and talk about the anterior tibial dorsalis pedis intervention.
So based on the angiogram, it looks like the lesion is 95% stenosis, long segment disease, more than 60 millimeters. And so we're going to go ahead with atherectomy, basically a directional atherectomy catheter, the Hawk 1. Which has, so Dr. Krishnan will...
So I'm just going to explain the Hawk 1 to you. So it's not that we feel that Silverhawk is going to be the best at dealing with this, but I think because of the fact that you have a long diffuse lesion in the SFA, as you saw, with a focal stenosis, and calcium, the old Silverhawks, you would have to go with the actual calcium cutter, or what we call as a TurboHawk calcium cutter, which was a device that needed to have a filter, and really, in my opinion, was more of a chipper rather than a cutter. The particular Hawk 1 here, this is the new generation device from Covidien from Medtronic, and now you can see that it has a longer nose cone, so we're able to do more passes without having to clean it. Second, it has a higher RPM speed cutter. I believe it's, what's the rate? 800, is it? 800 RPMs as compared to the old one. And third, it also has a much more aggressive jog. Therefore, it opposes up against the artery, and you're able to get more cuts. The last innovation that they've made is they've attached the cleaning device to the Hawk. So this way, it actually speeds up your cleaning, which I don't think is as big a deal as the other things that we've done. So the initial part of what we're going to do is debulk this. Generally speaking, we would go with a Pathway Medical or some sort of calcium calcium cutter in this particular lesion. But now we've decided to go with the Hawk 1 and demonstrate how this is going to work. Dr. Wiley, Dr. Kapoor, any thoughts as we start to work?
So you would have considered using orbital atherectomy or rotational atherectomy?
Well, I mean, I know...
What made you use this device versus the other two?
Well, I obviously in our lab, you have probably the most experience with orbital atherectomy. I myself, I think it's a device that does work. Can you mag up, guys? Have not really used it in these kind of lesions in the SFA, just because I worry about the luminal gain that we're going to get with an orbital atherectomy. Not very, very familiar with the crowns that are available, but if you want to, Dr. Wiley, go over that would be a great segue into management of these calcific lesions. But before I do that, let me just show you what we're going to do. Show me a little higher, guys. So what we're going to do is try to pass the Silverhawk. So the key is to pass the Silverhawk all the way down across the lesion, right? So that's what you want to do. So now you know the Silverhawk is going to pass, which was tight, by the way. I had to push a little bit. Okay, and then what we're going to do is we're going to put the angiogram up on the side and decide what's the level that we're going to have to cut from. So Dr. Guj is going to freeze this for me when he thinks it's appropriate. And likely we're going to start, he whispered to me 25 to about 35 is what we're going to cut. Sorry, sir. So we're going to start around 25. Actually, it's probably 20 cut, I think, right? Ray, is it 20 or 25?
I'll probably go with 25.
26. So we're going to start around 24. Let me start around 24. Let's turn it on.
Ready?
So go ahead, Jose. I'm sorry to disturb you.
So again, you're using in this case a 014 wire for this new device, correct?
Right.
Okay.
So just to keep the atherectomy discussion going on, it's an open question. Do you have any set thought process or protocol to say, okay, if the lesion is so complex or so calcified, or the lesion length that determines using one atherectomy versus the other? Like, Karthik or Dr.
I'm
Wiley?
gonna ask Dr. Guja to answer that one.
So basically, we have kind of a set protocol in Sinai. As Vishal, we all practice the same protocol. Nobody has any special preference to anything in general. Dr. Wiley is more experienced with orbital atherectomy, but usually if the lesions are very calcified, depending on the calcification, if the eccentric calcification, we consider directional atherectomy. If it's just a long lesion, directional atherectomy is better. We have long nose cones. We have to use a filter, especially if it's calcified, no matter what atherectomy device you use. But if they're really calcified, we try to do a pathway device or a jet stream, which gives us a better control. And because it has both thrombectomy, you can say it's more like an aspiration, kind of a mechanical debulking device. So it's easy. You can use a CSI device, which is also an orbital atherectomy, which is good in this case.
Exactly.
We in this lab are, except Dr. Wiley, are not extremely. We don't use CSI as much as we normally, other people probably normally do. We either prefer to use a Silverhawk or a pathway device or a jet stream.
Yeah, go ahead.
Go ahead, I'm sorry.
No, I was just going to ask you, so this device is technically now universal. You don't have the calcified and the LSC or the LSM like you used to have before.
We have an LX Silverhawk one, and we have an LS Silverhawk one. So we are using the calcium cutter here with a long nose cone. So anytime we use a calcium cutter, doesn't matter which device we use, filter becomes necessary.
Right.
May it be CSI or may it be a jet stream or may it be a Silverhawk. I think Dr. Wiley, out of all of us, has more experience with orbital atherectomy, the CSI device. I would ask him to just comment on it with the crown sizes and everything he has to choose.
Yeah, well, orbital atherectomy obviously would work in this case as well as rotational atherectomy.
Jose, what if you were going to do orbital atherectomy? Do you believe you're going to get a big enough lumen here, or do you think that you're going to have to do, or do you think the lumen is really going to come more from the actually go medial again? Lumen is going to go to medial and then rotate back, clock back. I clocked. So or would you what would your crown size be? Now clock till you go lateral?
I used the largest one. I think it's a 2.5. The problem is that still you're not going to have enough luminal gain. So essentially, you would have to then dilate it with a balloon. I think that orbital atherectomy in itself would not work. You have to combine it with.
So when you say it does not work, one of the thought processes that they all say is that orbital atherectomy is going to off here. So you can see here there's a chunk of calcium that it wasn't eating through. Orbital atherectomy as such reduces the pressures that you can balloon in. Is that true?
Well, it modifies the plaque, so theoretically, instead of having to go high pressure with a balloon, you could probably dilate it with less pressure, decreasing the risk of dissections. You know, again, that all depends in the individual case. So I don't think that's a rule. That's the intention. But in most circumstances, you're able to get away with a low pressure inflation after you do your plaque modification, if you want to call it that way.
So with Silverhawk, we use the filter to protect us from embolism. What do you guys do with the orbital atherectomy?
I think for every atherectomy device, we should use a filter regardless of what it is. You know, as you know, in a orbital atherectomy, they say that the debris that's going to be liberated is going to be smaller than an RBC, but we know that's not the case in every single patient that we do. So I advocate, as you do, using a filter regardless of the atherectomy device that you decide to use.
Well, it's interesting because everybody says different things, right? I'm just moving it, yeah. Everybody says different things. I was at ACC and our colleagues and good friends from Detroit, Dr. Elder and Kaki, they don't use many filters at all in SFAs, especially all sorts of SFAs. I don't know if the algorithm is with calcific SFAs. They were very quite clear that their filter use is very low as compared to ours. So it's pretty interesting because, I mean, the way you and I have seen it is that, you know, obviously we teach fellows as they do, that our filter use has saved us a lot of trouble in multiple times.
Of course, until you get into trouble. So there's a lot to gain using a filter. There's very little to lose. Yes, you increase cost, but the benefit that you get certainly outweighs the risk of using a filter and the cost, in my opinion.
Show me the filter. So we're going to show you the filter here to see whether we have the filter come off PSA. Put it on normal.
I guess specifically in this case, when you have a patient with active ulcer, you want to make sure you don't do more damage than what you begin with, especially with the runoff. So you always is better, and with so much calcification, I think it's best to use a filter in order to protect any distal embolization, and then you're chasing distally down, aspirating,
The worry, I guess, becomes the cost, Vishal, as you know, and seeing this, obviously, we don't have any debris, thank God. The worry, obviously, becomes the cost. So the issue here is now you saw the picture from what Dr. Guja just showed you. Go minus, Karthik. So the filter doesn't have debris minus. The question is now, this is our post three-wall atherectomy cut. So the question is, would you guys do another atherectomy cut? Would you do something different at this stage? I mean, what are your thoughts on how you would deal with this in this particular lesion?
I mean, the luminal gain is very good. I mean, you can see the focal lesion is gone, and you have nice cuts, and there's not much of real concern dissection. So I would probably just go up with, and if you have to, use a DCB and see how the results are. And
so the question is, what are your guys' opinion on DCB in these kind of calcific lesions? You saw fluoroscopically, there's obvious calcium, right? Let's go with the regular first. Obvious calcium, and the question becomes is, how do you guys deal with these kind of lesions, and in the role of DCB, DES, or Supera in these kind of lesions in this kind of clinical scenario?
Well, Prakash, I think the data is pretty compelling. Using a drug-coated balloon right now in lesions such as this, I think you've already used your calcium cutter or your atherectomy device, opening enough lumen that you should be able to fit a balloon and deposit the paclitaxel, reducing the risk of restenosis.
But Jose, as you know very well, I mean, Finelli showed very clearly that in moderate to severe calcium such as this, which is basically the arc of calcium covers about 3/4 of the vessel wall. Here it's probably severe calcium. DCB results in a greater late lumen loss and then likely a higher rate of restenosis. and then they feel that DC may be a barrier to these particular types of cases, meaning calcium may be a barrier. So the question is, and plus this has never been studied in a randomized controlled fashion, because you have a guy with tissue loss, and the question is, the only data we have with DCB with tissue loss that's randomized was the Impact Global trial, and the Impact Global clearly showed actually a worse outcome in this particular kind of in these patients. So to me, the reason I ask is, in this era of DCB, go above, guys. In this era of DCB, oh, you went with a short balloon.
Yeah,
okay.
we have to give it with the 80,
Okay,
right? We
go ahead.
100 balloons.
Well, remember, but we treated longer.
Because the problem is that with calcium, nothing really works very well. So regardless of the device you use, restenosis is going to be higher than if it was a non-calcified lesion. So
yeah, but I guess you could make an argument of using Supera, because if you look at the Superb trial with moderate to severe calcification, the 1-year patency is pretty impressive, 83%. In mild calcification is almost 90%. So I guess if you really, like Dr. Krishnan said, with the amount of calcification, the femoral region, I guess Supera could be a good viable alternative, or it may be a primary treatment of choice in this case.
So you can see here. So as Dr. Kapoor just went over very nicely, Supera, clearly shows that in the Superb trial, the average lesion length was around, I believe it was 7.2.
Right.
If you look at 7.2 lesion length, you have a patency rate that was around, primary patency around 83, 84%, or even 88%. I can't remember the exact number. Right. So if you look at Supera 500, the average lesion length went up to 12.3 centimeters, and your patency obviously dropped off at 1 year from 80 plus to around 74 plus. So the longer the lesion, obviously Supera seems to work better than most lesions. And if you're a TLR believer, the TLR rates also lasted out to 3 years, and pretty much depended on how you deployed it. So the question here is obviously stenting, scaffolding with Supera, which is great data. Obviously non-randomized controlled registry, but core lab adjudicated data. Is an option. versus atherectomy with balloon. So let's look at the atherectomy with balloon data. If you take definitive LE alone, and if you take definitive LE in say non-CLI and claudicants, and you look at long lesions greater than 10 centimeters, definitive LE is going to give you a patency
70%.
of around 60%, 60, 62%. Overall, definitive LE patency was around 74, 76%. I can't remember in that range. But when you look at the longer lesions with atherectomy with balloon, it was around 60%, so which was not exactly an ideal type of patency. If you want to extrapolate the DCB data, if you look at obviously, if you look at impact SFA with the average lesion length of 8.9, you're looking at a patency rate at 1 year of 88.4%. So you know, you've got a lot of data out there that you could extrapolate. Unfortunately, in this lesion that you and I are looking at, it really becomes a judgment call. And the judgment call is, okay, well, I've got calcium. I did atherectomy because I felt like I needed to break apart the calcium and debulk as much tissue as possible. That's my philosophy. I'm not saying that it's correct. Second is, you know, now do you need to do anything adjunctive other than a balloon in this particular case? Because, you know, the question is, what is the role of patency in the healing of this wound? Or do we first see whether we can get through the AT first and then decide how to treat this? That's the question.
Yeah, I think that the healing is not completely dependent on this SFA lesion. Obviously, the infrapopliteal lesion is the one that's causing his ulcer. I think it's important, this lesion, because it's the inflow to the infrapopliteal compartment. So whether you use a drug-coated balloon, whether you use a Supera, you know, either approach I think is appropriate, and nobody could fault you for using either alternative. The question is, what are you going to do below the knee?
Well, the question is, do you need to decide on DCB below the knee at this stage? I mean, not DCB, on treating this lesion at this stage, or do you first go below the knee, see what's the outcome, of what's the result you get, and then decide whether you need to stent or DCB or whatever this particular lesion? That's my question.
Well, I don't think it matters as long as you get your equipment
how
down.
important does patency become if you get straight line flow? And I think that's the great question in life, right? The question is, do you want to go ahead and treat this particular lesion with a DCB and say, listen, patency is important. I'd like to get the best patency as possible, or a Supera or a Zilver. Now, you know, I never spoke about the Zilver PTX data. Zilver PTX data, especially the global registry of Zilver, is basically like Supera 500, around 12.3 centimeters. They also had an equal number of occlusions. They also had an equal number of what is it called, calcific lesions. So therefore, if you look at Zilver PTX with a fracture rate of 0.9%, okay, in these lesion subsets, you also have very, very good primary patency data with the Zilver PTX at 1 year. So if you look at the PSVR ratios used in Supera 500 versus the Zilver PTX, the Supera 500 PSVR was 2.4, while the Zilver PTX PSVR was 2.0. So, I mean, there is a role rather than DCB if you're a scaffolder to put a scaffolding. So now, let me pose the question. So I took everybody on a big tour of data here. Let me pose the question to Dr. Guja, to you, Dr. Wiley, to you, Dr. Kapoor. One, who's in favor of atherectomy and balloon alone?
So wait a minute. What are your other choices?
Right. Okay. Two, who's in favor of straightforward bare metal stenting after atherectomy? Three, who's in favor of DES with Cook stent? 4, who's in favor of DCB? 5, who's in favor of Supera? So I'll start with Dr. Guja.
So I have always preferred no stenting technique. I mean, that's always been my preferred method. There is no data on DART therapy, at least in the United States yet. So I think it's an interesting trial. I think Europe is looking into it. I think that's the future of peripheral interventions. I would go with atherectomy and DEB based on what you see on the angiogram after the predilatation. If there is no severe dissection, I think you can safely go with DEB. Here, I would probably go with the DEB.
Dr. Wiley?
I agree with Dr. Guja.
Dr. Kapoor?
Well, essentially, it's the same therapy. I mean, you know, it's a severely calcified lesion. So if we just argue about patency, we know almost at the end of 1 to 3 years, we'll have virtually similar patency rate and TLR with Supera or DCB, even though there's no head-to-head comparison. So
well, that's not true, because there is the propensity match analysis out of Germany. I know it's single center. It's done by Scheinert's group, who's
Right.
coming to our symposium, as you know. They looked at 5-year propensity match analysis, which is not obviously very powerful in terms of its relevance because it's not randomized and it's not head-to-head. But however, they match the lesions, they match the lesion lengths and the patient characteristics, and they follow these lesions out to 5 years. And what they found was very interesting, that Supera was obviously the primary winner of the patency and the TLR battle. Second was actually bare metal stent, and third was DCB. And this brought up the entire argument of why I'm coming back to you guys, is the importance of scaffolding. So if you're worried about scaffolding, you worry about fracture rates and you worry about future therapy. Right. So the fracture rates are negligent with Supera and basically are negligent with the Zilver PTX if you look at the randomized trial data at 0.9%, right? So the question becomes is, well, do you do a DES with a Zilver PTX, or do you do a bare metal Supera saying that I have data out to 5 years with Supera in this type of lesion? And that's my reason why I bring it up, because I think that at today's day and age, this is an unanswered question. What is the role of scaffolding in drug-coated technology? Is the late loss that we're going to have in these particular types of lesions at greater than 1 year because of a lack of scaffolding? So that's my question, because at the end of the day, the drug is gone, the biologic effect has already occurred, and does it become a mechanical issue down the road in the pattern of restenosis?
I think so, PK, especially in calcified lesions. Don't you think Supera, theoretically, would serve better? And the propensity, of course, the power was not great for the study, but still, I would say Supera, because in the SFA lesions are not like coronary lesions. They are not like, I don't think I think drug makes a difference, but because the drug runs out, I think the mechanical forces make a big difference in the peripheral artery system when compared to coronaries. So I think Supera definitely makes a huge impact in this kind of cases, especially when you're talking about longer stents, especially when you're talking about areas where there is more compression, like adductor canal areas, popliteal areas.
Mm-hmm. So
I have a problem with all this propensity analysis.
Exactly.
Right.
You're talking about subgroup analysis of multiple trials, and trying to make conclusions out of this, I think, is unfair and is inappropriate.
Listen.
I think it gives an idea what may be going on, but I would not draw any conclusions whatsoever based on this.
It's essentially an hypothesis generating stuff. So we do this subgroup analysis and propensity to generate a hypothesis for further investigation. I was just going to say it's just there's no randomized trial essentially to compare.
Absolutely.
So
Plus,
in this case,
there are not power to show
Right.
that either. So.
Well, guys, listen. Unfortunately, in the endovascular arena, as we all know, I've been in it, and Wiley's been in it longer than the two of you. The point is, there is not enough data out there, and we really do struggle at this stage to make decisions. And and that's why I bring up this thought of what is the scaffolding and the role of the scaffolding in these type of lesions. So right now, we've obviously stayed away from a stent. I'm sorry, sir, I know it's going to be a little painful. We've stayed away from the stenting in this particular case. So we've gone ahead with a drug-coated balloon, and you can see the drug-coated balloon is going to be left up for about 2 minutes. I'm really not going to talk about what drug-coated balloon I use. I really think the data is pretty strong with both of them, so I'm not here to say one better than the other. I think that here we decided to do the drug-coated technology because I personally and firmly believe that atherectomy and balloon alone in this type of longer lesion is not warranted. The only question here is we atherectomized longer than this particular lesion, and we went with a 100 balloon. So the question, what I'm going to do offline, is obviously we're going to save this to the side. We're going to come back for the sake of time, and I'm going to have Dr. Guja and myself. We're going to go ahead and balloon the entire atherectomized area. So we're probably going to have to go all the way down to probably to around 10, and then up to around 24. So this way we cover the entire segment that was actually damaged by the atherectomy catheter. So this is going to be our strategy for the SFA. Now, what I'm going to do is, guys, can you give me a fielder? Actually, a fielder and a fine cross, please. What I'm going to do here is, actually, you know what? Yeah, give me the fine cross. What I'm going to do now is go ahead and get through the anterior tibial artery, and then we're going to talk about how to do it. So we generally leave the drug-coated balloons up for about 2 minutes to 3 minutes. So at this stage, the drug-coated balloon's up. Ray is going to prepare the fielder and the fine cross. And our methodology of crossing these lesions below the knee is basically going to be a wire technique. So as you can see, we're at about a minute and a half, and Dr. Guja is going to bring it down. We'll take one picture, capture the filter. Give me a trailblazer, not a trailblazer. Give me a vert tip catheter, guys.
Prakash, you mentioned that you're going to try to open the AT, and I'm going to post a question: why not just open the proximal perineal lesion that, as you saw, has a very robust collateral filling the dorsalis pedis? It's almost a straight line flow that you have.
Well, I think that's great question, Dr. Wiley. I think it brings back the philosophy of what Dr. Guja has all presented in the past when we talked about CLI. I think the question is whether you believe in indirect revascularization or direct revascularization. Obviously, the theory of what Dr. Wiley is talking to the audience is that indirect revascularization is when you're going to use the straight line flow into the collateral to provide nutrient flow to the area which needs the blood, which is the ulcer. However, in this case, I mean, what I'm feeling is in this kind of patient who's had multi-level disease, direct flow would be better if I can achieve that. If I can't achieve the direct flow, then I'm definitely going to go and open the perineal, and that was going to be my strategy, Dr. Wiley. Okay. I was never going to plan on, again, give me the, let's take a little picture, maybe nothing in the filter. I was going to plan on not opening the perineal if I was able to get direct flow via the anterior tibial into the dorsalis pedis. So now we're just going to check our filter before we pull it out. Always, we're very paranoid about checking the filter, as people who have seen us in the past know how we do it. So you can see there is no goobers in the filter. So we're gonna use our trailblazer catheter to pull the filter out, and then put our 014 wire through this, and then walk it out. That's gonna be our plan.
Dr. Wiley, for the question you posed about the peroneal, I agree. I think if you have an artery which has a direct, which is the artery for the angiosome. That angiosome, I think we should attempt it, especially if that artery is a CTO, because I think the restenosis rates below the knee, no matter what kind of method you use, are pretty high. I think everybody agrees on that, right?
Well, that's pretty interesting, because I was looking at the data with definitive below the knee, and definitive below the knee clearly shows that atherectomy below the knee is not what is it called, dependent on lesion length. So if you look at greater than 4, I mean less than 4, 4 to 10, and greater than 10, you'll see that the patency rate is around 80-something% at 1 year. So which is pretty interesting, which is actually the only data, can I have the fielder please, that has really shown any sort of patency below the knee. And in diabetics and non-diabetics, with the atherectomy data, you clearly have good results in terms of restenosis rate. So that's the only thing. But I agree with Dr. Guja, in these type of long segment, this is not a 10-centimeter segment. This is probably a 30 to 40-centimeter segment, 30-centimeter segment. So you're talking about a long lesion, and obviously you're going to need a blood flow at least for 3 to 6 months. Thank you. For you to be able to keep this one open.
Right, and also because of the restenosis rates, now you are making an artery which is 70 or 80%, and with the restenosis, who knows, it's going to branch.
And I'm in the collateral.
You might make it a CTO. I think it's worth trying the AT. I mean, we all know that our success rate for below knee CTOs are about 90%. Most of the times we get through it. So I think it's worth trying a CTO than trying something which is like 70 or 80% and making that vessel more restenotic.
All right, hold on, let me walk this out. And give me the trailblazer, guys.
Do you agree, Dr. Wiley, or?
No, I do.
Oh,
I do.
Vishal, what is your practice?
No,
what would you do?
I agree with you. I mean, we'll obviously try to go direct revascularization and see if we can get inflow directly through the AT and heal the segment. Oh, wow. But if for some reason we're not able to do it, perineal is a very good option in this case to treat it and get the collateral flowing into the segment area. So it's essentially direct versus indirect revascularization for angiosome stuff.
So you can see here that the only difference that we do here is we're incredibly aggressive with our choice of wires. We generally just go with either the Confianza Pro 12 or the Win 200 family of wires. And what we generally do is just start with that very aggressive wire technique. Obviously, can you pull rail, please? Don't let the wire go forward. As you can see here, that as you know, that there are multiple crossing devices. I'm just curious, for conversation's sake with the panel, what are the choices of crossing devices that you guys like? What are the other things that you guys like to use in these kind of lesions? Dr. Wiley?
Well, I'm an advocate of cost savings, so a good wire technique with
Thank you.
support catheter behind as you're doing, I think, is the
So
the
when
most
do you,
effective
so
approach.
when do you go with a crossing device?
When the wire alone doesn't go, sometimes if I think that I may be going suboptimal, then I'll try to use a device such as the Viance device that may be helpful.
So the
Most
advocate-
of the other crossing devices, I'm not a big fan of them.
The advocates of crossing devices would say that you've already created a dissection plane, and now your chances of succeeding with a crossing device are even lower because you've already done that.
I think that the Viance device has shown that if you locate it outside of the dissection plane, works quite well, at least.
Yeah, but I'm saying that once you make the dissection plane, you've reduced the efficacy of that particular device.
Well, with any device,
Why?
even with the wire as well. You make a dissection,
So
you
that's
make
kind of
case
the
more
question why
complicated.
you would not go with a crossing device first. A Torker, Ray?
You know, again, you got to think of costs when you do these procedures, because the next question would be, if you're concerned about having a dissection, that means you're advocating to use a crossing device in every single
Give me the
case.
field back.
That's probably not the appropriate way of treating these lesions. So you're always going to have a risk that when you intervene, even with a crossing device, that you will have a dissection. So to say that I will use a crossing device to prevent a dissection will not be appropriate. And number two, to say that I will not use a wire because I have that risk, that means that I will be advocating to use a crossing device in every single case that I do below the knee, which will be inappropriate as well.
I guess it's essentially a judgment and an operator call. For me, if the lesion is long, if there's a lot of calcification and you want to try to keep it intraluminal, I'll start and give it a shot with a crossing device. But if it's a short focal lesion, you can see the distal flow is good, then a wire and a catheter technique works as equivalent to a crossing device. So,
So you could see these are more subtotal occlusions than full occlusions. I'm able to pierce through. See, right there's a little occlusion. Getting through that, now I'm going off the other way, which I don't really like. Okay. So a lot of times, guys, for the audience, I mean, it's not that, we're this good or whatever. I think the point is that you have a lot of underfilling of these vessels because of the occlusion. There's definitely an occlusion here. We just got to find it. And I think I'm there. See, I'm right there. That's the occluded segment here. Can you guys show me, put this in the center of my screen, please? So you can see here that, can you go a little, Liz, don't worry about that. Nothing. So I think we're here now at the occluded segment here. So I just want to make sure that we'd use a good technique to get through here.
Prakash, I wanted to make a comment of what you said about the definitive study below the knee. Again, the data is very limited. This is a registry, and we've talked about it 1,000 times. So, I would like to have a comparison between apples and apples and not apples and oranges. They're two different things. So again, I'm very skeptical of all this information that we're getting because we don't have level 1
I
evidence.
just don't like the way that's going. What's that, bro? Can I get a new
I'm
pair of gloves
concerned
for a
about,
second? I got a hole.
you made a
What-
comment
what's
about the definitive study below the knee.
Right.
In my opinion, this
No,
is
the
still
other one, the other
limited
one.
data. This
other
is a registry.
Right.
I
But-
would like to have, if we're going to talk about patency between different devices, that we're comparing apples and apples and not apples and oranges.
But Jose, the point is though, if you talk about data, you have to have data that's level 1. You can't always have data that's level 1. Unfortunately,
I think it's our responsibility
unfortunately, we don't
now.
have level 1 data in this particular area, but it is core lab adjudicated, and it does have a lot of value. See that?
That is great, but that doesn't make it level 1 evidence. It looks good, but it's not enough. And I think that it is time now for us to ask for level 1 evidence. Just because you have core lab adjudication, that doesn't mean you're making this study a randomized trial. It is not.
well, I guess with the advancements and with the number of peripheral procedures and the interest, I guess, like Dr. Wiley said, it comes as a
need to
bonus
see
to
my
us
two white
eventually
cups.
to
Yeah.
do a head-to-head trials of various devices and procedures and techniques to give a real world data to people to see how it works.
So I don't know if the audience saw that. Dr. Guja very astutely went to another view and was able to see that, because we were both concerned here just behind the scenes talking about where this wire is going. We both weren't really happy with it, and he found that we went into a collateral and we were heading, now we're in the foot, and we were heading the wrong way. So it's very important for the gang at home who's watching. Oh, it's a little resistant getting down. So we crossed this lesion. Now we're in the foot. So it's important to remember. So he had basically a segment of maybe 10 to 15 millimeters, which was occluded, which is where we were deflecting off that collateral. Come forward. So now we're just going to check where we are. And I don't mean to interrupt the conversation, but I wanted to point that a technique out that Dr. Guja just so nicely showed. So what he showed was exactly what you need to do. DSA guys. So we actually placed this in a collateral, and we're moving it. No move, sir.
Nice.
So now you see that the blood supply to that foot is coming directly from this dorsalis pedis to that toe. Give me this one, guys.
Percussion,
Command
Kartik.
wire.
As you know, it's become fashionable out there of getting pedal access. And I'm a little skeptical of the overuse of pedal access in a lot of these cases. When would you choose pedal access versus antegrade approach?
I think as you, me, and Vishal and Karthik have often done here, it's usually after we fail an attempt at antegrade approach before we go retrograde. I mean,
what is the downside of retrograde in your opinion?
Because we already use retrograde.
I think, Karthik, maybe you want to comment on the downside of retrograde?
So I think,
Give me an EXL.
I mean, some people exclusively use retrograde for all the below knee interventions. We can use it, but we are a big proponents of keeping the retrograde access for possible touchdown for bypass, especially in critical limb. So I think downsides are extremely minimal. We can use it if the operator has to be really comfortable with retrograde, and of course you should have
A little more, bro. No, it's out. Go ahead.
So you should have a good ultrasound. The operator should have good ultrasound skills. You can do it under fluoro, but again, when you're talking about also critical limb, fluoro gives you only limited kind of supply, especially subtotal lesions like this. You don't know where to stick.
And you guys have seen us fail trying under fluoro in a very difficult case in the past. So, and we've also succeeded alive as well. But I think that what Dr. Guja is saying is that we generally reserve it for when we fail an antegrade approach.
I agree with Prakash's comment. I think that yes, you could get access transpedal, but the worst that could happen is that you have a complication in the sole transpedal vessel that you have. Then it's very difficult to fix. So I would reserve it as a last resort if nothing else works.
Right, I agree. It's like I mean, basically, I mean, you're taking the only reason you're having for the patient to have surgery out by doing a transpedal.
Correct.
I think you should always give it an antegrade approach, and if you fail antegrade, which I think the antegrade success rates in peripherals are much higher than coronary rates. I think, I mean, being in Sinai, I think we have 90% success rate going antegrade. I can pick and choose cases where we had to go pedal to get access. But I think all of us agree, right, Vishal, Dr. Wiley?
Yeah, I agree to it. I mean, I guess antegrade remains an access site, the route for choice, and especially below the knee. And if you really have to salvage it, then of course transpedal always is a viable alternative in this case.
I think the only problem antegrade comes is when you have a tortuous arch, you don't have enough supply. You don't have enough support, but you can always go antegrade common femoral access for it, which is probably a good way to do it.
So, in this case, as you know, drug-coated balloon studies below the knee have not been very compelling. Even though theoretically, you know, I don't see why it doesn't work. What's your comments? Would you continue using it? Do you think that the study have not been well designed?
But I think the studies which were done have exclusively used only drug-coated balloons, but they have never tried atherectomy. I think Dr. Graziani has tried it, but they have never tried atherectomy with DEB. Again, the same dart therapy I'm talking about.
Well, let me comment on that. First things. First and foremost, the randomized trial with the impact balloon called Impact Deep, ready to inject Impact Deep, showed that there was an adverse outcome in terms of higher rates of amputation, actually death in the DCB arm. Okay. So now, having said that, Okay, what are some of the things that were issues with that particular trial, right? So he's moving obviously, but we got flow. So some of the issues with that trial was that it used an old generation balloon with old generation coating technology, okay? So that's not the current impact balloon that we have available in America. Matter of fact, that's a balloon that's off the market currently. So one of the things was that there was embolization, show me below, that occurred from that balloon, okay? So I don't know whether we can truly extrapolate anything from that trial other than to say that particular balloon does not work below the knee.
But there was higher thrombosis rate.
Well, having said that, you have two trials via actually right about here is good. Yeah. Via ongoing as we speak. One is with Lutonix, which is actually going on in America, where we're going to be able to find out the true answer. So I think the truth of the answer is that there is no current randomized data available for DCB below the knee. The data that is available is a negative at this stage, and we don't know whether that's going to be true as we go forward. So what size balloon are we using here?
So that means you will not use it, or you will use it in certain cases, or what would you do?
Oh, okay.
It's a big balloon. It's just right on the shin.
Okay, it's on the shin. I see it. So at this stage right now, there is no available DCB below the knee, Jose. There is none.
If you had it available, would you use it with the data that we have right now?
I mean, right now, I don't. Well, first of all, it's not available because the FDA is not going to make it available. Second is, if it was available, I think I would wait for the data to get more robust. I think the data we have with UConn and other DES is actually a little more robust than we have with DEB. So at this stage, the patency rates are better with DES, but the question is there's no reimbursement with drug-eluting stents, at this time below the knee, so that's why we tend not to use DES. So at this stage, to answer your question earlier, there is no randomized data available. In my opinion, the best data below the knee that's available at this stage in terms of core lab adjudicated, large number of patients is the definitive LE. Right. So if you believe the definitive LE data, you would do a directional atherectomy like we did here, followed by a prolonged balloon, and that's our hope.
So you're using a 2.5 long balloon?
We do. So this is a tapered balloon. There's only two tapered balloons in the market. One is by Medtronic, which is the Ampheron, and the second is by now Medtronic, or Covidien, which is the Nanocross, and this is a Nanocross. So they chose a 2.530, which I don't think is wrong. We're going to go up. We're going to leave it up for a long period of time here, and then we're going to go ahead and be done. So as you can see, guys, we started this case at 8:10. It's now 9 o'clock. We've now done atherectomy balloon of the SFA, and we've done atherectomy balloon of the Infrapop in 50 minutes. So, if anybody who says that a multivessel intervention in the SFA or atherectomy in the SFA takes a long time, that's not true. I just think you have to be efficient in your approach. You have to make quick decisions. You saw all the thought process of all the operators here in making these decisions. I think it's important to take all those things into consideration. So now Dr. Gujas just dropped the balloon here. Now,
Raj, would you mind going in terms of your atherectomy technique below the knee? How many cuts did you do?
Well, below the knee is interesting because generally speaking, we only do 2 cuts below the knee. I only did 2 cuts. Actually, I only did 1 cut here. Yeah. For the sake of time, I would have made another cut, but I don't think it really makes a difference. We generally do 2 cuts below the knee. So we do 1 cut that's lateral and 1 cut that's medial. But this balloon, you have to make sure you don't go above nominal. And here nominal is around 8.
Why not 4 cuts?
Just because I think there's not enough in the vessel there. I think the device is quite aggressive, and I think your chances of perforations may be high. So generally speaking, I don't do more than 2 cuts. Sometimes I just do 1 cut to get flow, and then I balloon it.
What's your anticoagulation of choice in below the knee interventions?
Below the knee, we basically off-label use bivalve. As you know, the Endomax trial is ongoing and we're a participant to see whether there's a indication for Endomax for Angiomax at the level of the PAD. There's safety data. There's safety data with bivalve both out of CIS and multiple centers that clearly show that it's safe to use. However, right now there's no particular indication. We do use it for longer cases below the knee as well as for longer cases in the SFA.
Prakash, the concept of using these 2 cuts with the atherectomy device below the knee, where did this came up from? Is there any data that shows that 4 cuts have higher perforation rate, or somebody made it up, or what?
Well, unfortunately, as you know, I don't think you can have randomized data for everything. I mean, some could say.
No, in registry, is there a higher perforation rate? Is that a fact, or it's not?
I think it's really anecdotal from experienced operators. I mean, in our lab, we've probably done close to 3,000, 4,000, 5,000 atherectomies. I can tell you that our perforation rates are very low, and I think in the beginning we were aggressive. We did multiple cuts in the tibials and have gotten into perforation. The second area where you have to be careful is where you have bias.
So do you think there's a higher risk of adventitial cuts below the knee if you do 1, 2, or 3 cuts, and that may increase restenosis
I
from
think give me a low
the study that you conducted?
I think this is only going to, I want to see the foot only.
Yeah.
I think you're only going to see that occur if you are very aggressive with your atherectomy. I think adventitial cuts are going to occur no matter what. So I think that I would not worry about that. And in this particular case, I don't know whether or not it's going to make a difference in the patency. My goal here is to get straight line flow into his foot, and hopefully he'll heal his wound, and that's our goal. And you can see here, even after this, the flow is actually not that good, and hopefully we'll see that we'll have flow through that. No, don't move, sir. Liz, can you wake him up, please?
Have you given any vasodilators?
We're going to give it now. You can see there is you have straight line flow.
Right.
So now I'm going to give some vasodilators. Give me a 018 Trailblazer, guys.
Just take this and just give it through the
Yeah, we can give it from the proximal AT. Yeah. We're going to go ahead and
No, you look at that.
actually we can try to give it through the sheath. Give me a
Give it from the top.
no. We'll give it from the sheath. It'll be good. Give me a nipride. 50 mics here. Hold on to this. What's the blood pressure?
Are you concerned of distal embolization into the dorsalis pedis with the atherectomy device?
120.
I'm sorry. What?
Are you concerned of distal embolization into the dorsalis pedis when you use an
There is always a
atherectomy
concern
device?
when you do atherectomy of any kind of atherectomy and below knee lesions. But I'm not really
Sir,
concerned about
don't move your leg,
that
okay?
in this case, Dr. Wiley. I think he's just moving, and I think there's a lot of flush in the sheath also. I think we just gave it some nipride, and we'll see. I think we have straight line flow, and I'm pretty sure we have adequate result here.
Hold on a second, Flora. Okay, don't move it. Let me see it right here. A little lower. There you go. Don't move your legs, sir. Okay.
Ready?
Yep.
Inject.
Skinny.
The flush is there. We just flushed it. Oh, there you go. See, it's already there. You can see it.
So we have a little spasm down below.
Right.
So the question is now, you can see that it's good flow, but did we balloon that area? We got a little bit of spasm.
How long did you keep that balloon up?
We didn't keep it up long enough.
Okay.
You want to just give some.
Well, it looks very nice, actually. I mean, I'm sure after.
You got straight flow. I'm
Yes.
just going to have to. And this is a great point for everybody. You see the spasm occurs. So give me a 20200 balloon, guys. Show me down below.
You want to take a picture here?
Okay. Don't move your legs, sir. Go ahead, Ray.
Go ahead, Ray. See, it's actually pretty fast, and you have a straight line flow.
You know, perhaps in the proximal portion you could use another balloon inflation
Yeah.
with a 3.5 balloon. I think the problem is up there, not below.
No, you clearly have a spasm below.
Yeah, but I think the problem is in the proximal AT.
What's the
Probably
matter?
another balloon
We're not talking to you,
inflation
sir. You're fine.
Let's say 3.5 may
Give
suffice.
me a vertip catheter, guys.
I think it looks very good. I mean, we've been intraluminal. We have direct online flow. We just have to do a little bit of modification, just proximal little balloon and
Right.
some
So
prepping the vessel, and it's
So
perfect.
let me sum up for the audience here, because the rest of it is just touch-up work. So what we're going to do now, show me above, please. Mag up, please. What we're going to do now is take the catheter, the mag up here, please. Take the 035 or these 4 French vertip catheter into the tibial. So what I'm going to do is place it at the ostium of the tibial. I'm going to get more nipride. Can I have more nipride, guys? And verapamil mix. Take out the wire, please. I'm going to take out nipride verapamil mix. And what I'm going to do is I'm going to treat this directly, and then I'm going to go ahead and then I'm going to do a prolonged balloon angioplasty of the distal and the proximal anterior tibial. We already got the vessel open. After that, if I doubt I'll have recoil because I don't have dissection. If I have a recoil or dissection in any spot there, I may consider a drug-eluting stent placement if I feel that the wire is going to cause, if the dissection is, what is this now?
That's verapamo.
How much?
2.5.
So the whole thing?
Yes.
Give the whole thing?
Yeah.
Okay. So at that stage, I may go ahead and use a drug-eluting stent.
The whole thing.
If that's not the case, then I'm done. I'm going to go back and drug-eluting stent the proximal. I'm going to drug-coated balloon the proximal SFA where we treated with atherectomy but did not treat with drug, and then we're going to be done with it. So I'm going to stop here. It's 9:05. We'll take this final picture, but now you know basically we're done with this case. We're just doing some touch-up. We're under our hour that we want to be, and we're going to be done. I don't want to take up too much of your time. Low mag, please. So I'm going to give you a nice injection here to show you how it looks after verapamo. Sir, don't move your leg, my friend, okay? Thank you, my friend. Okay, Cindy.
So as you can
Much
see,
better.
Wiley, it's like it's most of the time
Please
it's
show me
all
below.
spasm. So
Right.
Sir, you're moving your leg. Don't move your leg, sir.
Can you angulate the camera a little more?
I know.
yeah,
so-
he's moving a lot.
Well,
so
it's because of the ulcer that, hold on, Flora. Hold this right here. Okay, let's try that. Show me a little higher. Cindy. Don't move. Thank you. Don't move, sir. So we need to treat that segment right there.
Yes.
Yeah.
You see that segment needs to be treated. So once that segment is treated with prolonged balloon, then
think
we'll
it
go.
should be fine.
Then we'll go ahead and we'll be done. So again, I want to thank all of you. I want to thank Dr. Wiley. Thanks Dr. Kapoor. So while Dr. Guja wires this and gets to work, I just want to go do a quick recap. I'm going to do it here rather than do it outside because we got a very busy lab a day here at Mount Sinai. So the bottom line is just to recap, this is a gentleman who had an ulcer with multi-vessel disease of the SFA and of the tibial artery. So our initial principle was to do the angiogram and identify the area by angiosome which was affected. And in this particular lesion, it was very clear that the dorsalis pedis anterior tibial distribution was most important. We considered what are the different approaches to do this, and obviously we knew that we needed to get a straight line flow and a good pressure head in order to be able to get nutrient supply to this particular territory. So we first addressed the SFA. So at that stage, we talked about the different modalities of treating a calcified stenotic moderate segment SFA. We went over the data with atherectomy, drug-coated balloon, drug-eluting stent, bare metal stenting, as well as Supera. And we were able to go over and decide on an algorithm on what we decided to treat. We also went over when to use distal protection, when not to use distal protection, and in this particular case, we used distal protection along with atherectomy followed by drug-coated balloon stenting, drug-coated balloon angioplasty. We got a very, very excellent result, followed by which now we went ahead and we talked about how to cross this long segment chronic total occlusion of the anterior tibial artery into the dorsalis pedis. We chose a hydrophilic wire to enter into the dorsalis pedis artery, and then we went ahead and used a crossing wire such as a WIN 200 or a Confianza Pro to go ahead and get through. Once we got through and confirmed our position in the dorsalis pedis artery, we changed out to a command wire, and then we went ahead and did our atherectomy. We talked about the necessity of one wall versus two wall versus three wall cuts, and then we went ahead and did a prolonged balloon angioplasty, and as you see, we had a very good result. We did encounter some recoil, for which we're now going to do prolonged balloon again, after which we'll be done and stop this case. As far as anticoagulation is concerned, we used Angiomax, and we will go ahead and use antiplatelet therapy, dual antiplatelet therapy for the next in this case over a year because he has coronary stenting. So at this time, I think we're done. I'd like to thank Dr. Guja. Thank you very much for your input. Ray, thank you. Ricardo and Elizabeth, thank you. you too, Dr. Wiley. I'd like to tell the audience, and I know they're going to finish up, but before they tell you about the symposium, we're going to have 4 live cases from outside Mount Sinai, 2 from Leipzig, Germany, and then we're going to have 2 from Kingsport, Tennessee, 1 from Scheinert's group from Leipzig, and Dr. Schmidt's group, and 1 from Dr. Metzer's group in Kingsport, Tennessee. And hopefully we're trying to do exemplary cases to go ahead and show you, our technique and really the accepted technique of endovascular, and go over the data and really help your practice. So I thank all of you for your time, and thank you for joining us here at Mount Sinai. We'll see you at the symposium. Thank you, Dr. Wiley. I'll let you finish up.
Thank you. I want to commend you, Prakash and Karthik. This is a complex case made look easy, even though it was not. So you did a very good job.
It was an excellent case. Thank you for your input, and especially the data and the techniques. We will love, like Dr. Christian said, we have our CCVVC symposium. We'd love to see you there, June 17th through 19th, and specifically the endovascular and the endovascular fellow symposium. The next live case will be June 24th, so we'll see you next time, June 24th at 8 o'clock in the morning, Eastern Standard Time. Thank you very much.
Make sure to register in the symposium at cccsymposium.org, cccsymposium.org. The registration is open at this time.
Thank you.